For a client presenting with symptoms associated with ADHD, we chose to utilize the SNAP-4 assessment to be able to determine the primary concerns of the individual for any symptoms related to attention deficit, hyperactivity, as well as how these domains interfere with their activities of daily living. The reason behind choosing this assessment specifically over other assessments for ADHD was that this assessment is going to give an in-depth understanding of an individual's experiences with ADHD, as well as assessing for potential ODD symptoms across several domains, such as what their experiences are like within the home, within academic settings, with parents, and with teachers. From the bibliography research portion, we were able to find that the SNAP-4 has been effective for use among various clinical populations, as well as the 3-point scale that is utilized within this assessment was noted to have very high internal consistency among its coefficients, as well as the fact that the SNAP-4 is really helpful with determining ADHD and ODD diagnosis and being able to really assess what the client's primary concern is, as ADHD and ODD are a differential diagnosis that many clinicians have a hard time differentiating between. Utilizing this assessment will really allow proper analysis to be conducted to provide an adequate assessment to avoid a misdiagnosis. Specifically, the SNAP-4 will also give us a basis for how we choose to pursue our psychoeducation measures as well as treatment with ADHD, especially because ODD and ADHD often require specialized treatments, specifically like medication management as well as psychotherapy. And it's really important to make sure that a thorough, in-depth assessment is being done so we can give the best care possible, to make sure that we're treating specifically the correct diagnosis so we can really provide best practice when it comes to our assessments, our interventions, and the way that we're dealing with clients and their families to be able to address the concerns. And the SNAP-4 is a really great tool for that, to be able to kind of go over an overview that allows us to get specific within each different domain of potential ODD as well as ADHD symptoms to ensure that we are diagnosing the correct disorder and treating it as such. When looking at family background and situations with clients who are presenting with symptoms of potential ADHD, it's very important to utilize a family assessment that is going to be in-depth enough to give us an understanding of what the presenting family dynamics are, especially when working with adolescent populations, because we're really going to be working with the family as a unit. To be able to adequately assess the family dynamics, we chose the Family Assessment Device, or the FAD, to be able to really utilize a comprehensive questionnaire that's going to give us an in-depth understanding of the structural, organizational, as well as transactional characteristics that are going to be present within the different family dynamics, depending on many different factors. This is a self-reporting tool that's going to be given to all family members, typically as long as they're over the ages of 12. It's going to be 60 questions that go over a variety of topics, which is one of the things that make the Family Assessment Device special. It's going to really be under the three different kind of subcategories as structural, organizational, and transactional, but within that we have different topics. So effective involvement, effective responsiveness, behavioral control, communication, problem solving, and roles. So it's really quite comprehensive when it comes to the different domains that are going to be covered. And this device has also demonstrated great reliability across not only a number of different age ranges as well as different populations, and this is actually considered to be a staple among many clinicians. Its subscales have been shown to be effective, just as effective as similar in-depth interviews, clinician kind of one-on-one with families when compared. So this is definitely an adequate tool to be able to give the clinician an understanding of how the client views their own family dynamics. And this can definitely shape the way that we go about addressing different psychoeducation, different treatment goals, different interventions, specifically because we can really base these measures on how to minimize the current deficits or the risk factors within a family dynamic system, and also maximize the potential, so the protective factors. So, what is a family kind of presenting with? What are some of the things that we can kind of play on to be able to incorporate that into the individual's treatment? And what are some of the things that we can provide intervention on to be able to minimize, to make sure that we have the best shot at really effectively assisting with our client in terms of supporting their family as well, especially because with adolescents, we're really going to be approaching this as a collaborative piece. Specifically with an individual that has ADHD, really making sure that we are emphasizing the importance of family support with healthy expectations, really honing in on the importance of having schedules, of having goals, and keeping the individual who is being treated with a lot of accountability, making sure that the entire family is really on board with what's happening and also treating that person with a little bit of grace. Um, and that's really going to be tied into the psychoeducation component and element of intervention with the clinician and the family, making sure that we are taking a collaborative approach and maybe making some potential accommodations for the family member that's affected with ADHD.
So for this domain, we're doing physical functioning and health. The assessment tool that we're using is Connor's rating scale. So the purpose of this assessment is it helps identifies and assess symptoms, behaviors related to ADHD with children. The rationale for the instrument, it assists clinicians, evaluators with diagnosing children with ADHD, and it helps monitors like the severity of ADHD or the child's functioning levels, or if there's any changes in symptoms. To get affirmation from this, mainly parents can do it, children, and also the teachers can complete it. But I believe children have to be a certain age to complete this instrument. The insight from the bibliography. With the bibliography, the article or study that I chose, it was over maternal ADHD factors. So it did determine like mothers of children with ADHD had higher levels of ADHD symptoms. Um, they assessed children when they're about 8 or 9 years old in the study. Um, in the bibliography, they talked about the importance of considering those maternal ADHD factors with understanding the outcomes of children, including their own ADHD symptoms and for their overall well being. Implication for clinical assessment. Um, this assessment assists with diagnosing ADHD, diagnoses the severity, the treatment planning, progress, and it helps sees which interventions are useful for the child. Treatment in children with ADHD, CSR should be used to determine treatment decisions. It can determine like the treatment interventions. So like if medication is work will work, excuse me, if the kid need extra support at school, if they need like therapy and things like that.
All right, so this section is uh, about educational background and academic performance. So for this part of the assessment, we'll be using the Vanderbilt assessment scale for the teacher informant. So the teacher of the child that's presenting for treatment or assessment for ADHD will be completing the questions in this domain. So the purpose of the assessment basically to determine whether ADHD symptoms are observable in the child in a school setting. The rationale, the Vanderbilt teacher informant scale has been shown to be really helpful in gaining insight about the child's behavior in the class, in addition to their academic performance. The teacher scale includes items about the child's ability to, for example, like sit still, complete tasks, um, wait in line, things like that. And then further down in the inventory, there are questions related to performance in specific school subjects. And then, as was discussed in this research study, there only really exists it's like a low to moderate relationship between the ratings of teachers and parents on their respective Vanderbilt scales. So both the teachers and the parents were given their own specific scales to fill out, and then they later compared them to see how strong the relationship was between their responses. So even though that relationship was low to moderate, the authors maintain that the Vanderbilt scales, even when administered, um, when they're not compared to each other, they still provide really good insights about the presentation of the child, regardless of that lower inter-rater reliability. So we're still getting really useful information from both the teacher and the parent, when they complete the parent informant scale about how the child is presenting. And implications, the Vanderbilt scale can help to determine the extent to which the child's life is affected by ADHD-related symptoms. So it might be that in taking this assessment, because some of the questions on this assessment are geared towards oppositional defiance disorder. They also look for symptoms of depression and anxiety. It could be that maybe the child scores lower on items that are related to ADHD and maybe a little higher on items that are related to ODD, depression, anxiety. So that, of course, has implications for clinical assessment. We'd then want to refer the child and make sure that they're getting the appropriate care. And it would kind of let us know how we need to investigate further. Maybe we want to screen them for depression. Maybe these are actually symptoms of anxiety that are maybe presenting a little bit like ADHD. So it just kind of helps to parse out why the child might be presenting like they are. And then, as far as implications for psychoeducation and treatment, psychoeducation should be provided to not only the parents, but I think the teachers as well, just on how to best accommodate the specific needs of that child, because every diagnosis will present a little bit differently. Um, this could also involve advocating for in-school accommodations, like being able to take a test in a separate, quieter room, or advocating for an IEP, an individualized education plan.
When assessing a client's cognitive, psychological, and emotional functioning, it's very important to take into account the different symptoms that an individual is presenting with, specific to their potential diagnosis. And with ADHD, many individuals struggle with emotion regulation and impulse control. So, really assessing those specific factors to be able to incorporate that into your intervention to have some really specialized interventions is going to be really important. So we chose to go with the Emotional Regulation Questionnaire, which is the ERQ. And the ERQ is one of the most widely utilized assessment skills in determining an individual's capacity for emotion regulation. The ERQ specifically focuses on two strategies of emotional regulation, which is cognitive reappraisal and expressive suppression. This is a 10-item self-report measure. This is going to relate to the different cognitive reappraisal and expressive suppression within an individual. This is suitable for all ages, but specifically as we're working with an adolescent, most likely with severe ADHD, there is a child version, which is just a little bit of different style questions, which is more suitable towards younger ages. However, they are very similar, and this will give a clinician an understanding of how a client is going to respond to a specifically emotional, provoking situation. This is considered to be an adequate assessment, which is backed up by a meta-analysis which was conducted in 2019, which aimed to investigate the validity of the ERQ as a tool in assessing emotional capacity. And it concluded that the ERQ was a reliable tool to utilize among clinical populations, performing well in nearly every category of both reliability and validity. Utilizing the ERQ can also help determine the client's ability to respond in an appropriate manner as well as emotionally regulate. With this information that we can kind of really get from this ERQ questionnaire, even though it's only 10 questions, it will give us an idea, right, to use as a guiding force to be able to provide not only an adequate diagnosis, but also provide really specialized intervention. Incorporating the information that we get out of this assessment within the way that we really address psychoeducation is going to be important in providing adequate care to our clients as well as really involving their family, especially when it comes to keeping an individual accountable, on track with goals relating to impulse control and making sure that families taking kind of assessment as they go along as well, noticing if progress is being made at home in regards to impulse control and emotional regulation, because it can be very kind of different the way that a client presents physically in front of us, and also at home. So involving the entire family within specifically the emotional regulation and cognitive component of intervention is going to be really helpful in utilizing this assessment to kind of go more in depth with an individual's struggles in regards to these topics is going to give us the ability to provide a more specialized intervention with more catered coping skills, and really hone in on any specific emotional regulation struggles that an individual may have, especially as it comes to ADHD and a lot of young people struggling with that topic specifically when it comes to um, provoking situations.
So for domain 1.6, interpersonal and social relationships, I chose the Strengths and Difficulties Questionnaire, or SDQ for short. The purpose of this assessment is to measure the behavioral and emotional difficulties of children 4 to 17 years old with the goal of assessing for mental health concerns. The rationale for why I chose this assessment is because it uses a strengths approach for identification of potential mental health conditions such as ADHD in children. There are specific questions from this tool that focus on the child's ability to connect with and emotionally empathize with others, including their peers. It measures both their interpersonal relations as well as their relationships with peers. The insight gained from the Hansen et al. Study was that research uncovered children faced barriers to accessing adequate mental health care. Children identified as having ADHD did experience difficulties in their peer relations, and parents identified multiple barriers to getting care for this diagnosis. This indicates that there is a gap between the ability to diagnose conditions using this tool versus actually being able to connect with families and give them the appropriate resources to care for these conditions. The implications this has for clinical assessment is that it relies on participant self-reporting data, which I find useful as clients are the experts of their own strengths and needs. This assessment uses a Likert style, which allows clients to write their own experiences in a quantifying way, which is very useful for data collection. Personally, what I have learned for my future assessment would be to follow a 5-point Likert scale as opposed to a 3-point, as the study showed it was more effective. Additionally, I would want to use this assessment in conjunction with services that can be offered to families depending on their results of the questionnaire. For future psychoeducation and treatment, it is important that using such assessment tools like the SDQ, that we are not just aiming to uncover these underlying socioeconomic factors that can contribute to poor health outcomes, but we also need to be implementing supports that are assisting these families when they've identified concerns in these assessments. As we see here, diagnosis really only goes one step of the way to improving outcomes for families impacted by ADHD, and therefore parents also need to be educated on the stigma that surrounds ADHD and getting care for it. And educating them on what is the best options for their family and their child's health outcomes, I think it would be the most beneficial.
So for domain 1.7, ethnicity and culture, I used the culture gram as the instrument. The purpose of the culturegram is to gather qualitative information regarding the ethnic and cultural identity of the child and their family of origin. The questions that I've selected have been adapted from Congress's Culturegram, which was created in 2005. And they ask questions about items like ethnicity, community involvement, school culture, and much more. And as far as the insight from Congress's article, she really explores the significance of understanding the influence of culture and ethnicity when working with different client populations. She also demonstrates using an actual culturegram how, by exploring the domains within it, we can gain a much more holistic, well rounded understanding of our clients and how best to serve them. And so then when we move on to clinical assessment, we start to see how this culturegram really provides essential qualitative data regarding the day-to-day life of the child, information about their environment, their family of origin, attitudes that exist within the house, crucial insights pertaining to their cultural identity. And this has implications for psychoeducation and treatment as well. Because the culturegram provides such rich information about the experiences, the background, the preferences of the child and their family, we can then tailor the psychoeducation and the treatment to better fit these preferences and needs of the child. We should also take care to maintain cultural humility while working with individuals from different backgrounds whose preferences for treatment might differ from our own. So if a family, after completing the culturegram, it's revealed that their attitudes towards health, and maybe even specifically ADHD, is that they don't want to start their child on a stimulant medication. Well, that's good to know. Now we can explore maybe non-stimulant medications. Maybe we can explore managing ADHD through diet. So by understanding kind of where this family is at, we don't have to take a one size fits all approach. We can really tailor it to their individual preferences and needs.
So, with religion and spirituality, when it comes to screening for ADHD, I noticed as I was doing some research that there were a few different types of assessments used for this domain. So, um, I chose to talk a little bit about the antisocial behavioral scale. And this is the um, scale that is based off of a 1 to 5 scale. 1 being, of course, no um, presence of antisocial behaviors, and 5 being lots of antisocial behaviors. Also, um, the Strengths and Difficulties Questionnaire, which is also known as the SDQ, that was utilized, and that is only on a 3-point scale. And then also the um, FICA, which is more faith-based. So as you can see, it stands for faith, importance, or influence, community, action, or address. And this scale is, or this type of assessment is a set of questions that are more faith based. It is a little bit more of a lengthy questionnaire, but it does focus more on the religion standpoint of asking ADHD questions. The ABS was mainly selected due to more of antisocial behaviors being um, present more with ADHD in children. So with the antisocial behaviors being linked to ADHD, that's one of the reasons why the ABS was useful coming to screening the children. Um, this is also a great way to rule out any ADHD signs when it comes to the initial screening and the determination on if the child may have ADHD. As for the strengths and difficulties questionnaire, this is the most briefest, like, behavioral screener, and this goes for ages 4 through 17 years of age. And it also is useful when it comes to detecting any emotional of behavioral problems. So the research question and results, the research question I came up with was, is ADHD bound to be lower in religious individuals? And because all religions are, there's a lot of them, and they all believe in different ways of doing things. It was nice because all religions in this particular study, the behaviors were reported separately to like show those differences. And the results that were indicated at the end was that individuals that do practice, they report having lower levels of ADHD compared to non-religious individuals. So the implications for the clinical assessment, as said previously, the ABS was utilized more to help measure those antisocial behaviors that could be present in children, and was known to be very helpful with the process of elimination when it comes to truly diagnosing a child with ADHD. And the SDQ ratings were great to be like known to help diagnose with the hyperactivity predictors. And it is widely used to assess child and adolescent mental health problems. So the overview of psychoeducation when it comes to ADHD and working with religious individuals, these interventions can simply include the individual themselves, their parents, and teachers, and anyone else that is involved with the individual on a day-to-day basis. It is good to always have the parents involved with the education, and teachers also, because they're always with the child during the school day. And then lastly, this can somewhat appear to be difficult as all religions are different, like I said before, but mainly includes briefing the patient or client about their illness, problem solving, and lastly, communication. Moving on to gender, and what it looks like when diagnosing a child with ADHD. When looking at gender and ADHD screenings. The common assessment used is also the SDQ, because you want to also look at the client's strengths when working with them. And then the SDQ can be done in one of two ways. It can be done with self-reporting, or if the child is too young, it can also be filled out by the child's parent or guardian and their teacher. The SDQ has 5 measuring scales that go along with it. Those are emotional problems, conduct problems, hyperactivity problems, peer problems, and pro-social behavior. So looking at those 5 measuring scales, it would be beneficial for the child's teacher to have a part of filling this out, because they could observe this in the child throughout a school day or a few. And an important note, these are all scaled on a 0 to 10 basis. So some annotated bibliography insights. The SDQ, like previously said, is measurable in children from 4 to 17 years of age. And there's also another assessment, which I use a lot in my everyday career working with young children, is the ASQ. This is the Ages and Stages questionnaire. And obviously this is filled out by the parent, because it is useful for children who are 6 months up to 5 years of age. And the rationale for the instrument selection, the reasoning behind SDQ is that it aims with detecting any emotional problems that may be present in the child. And it is also universal when it comes to foreign speaking individuals, as it's offered in pretty much all languages, which is nice. And one of the most widely used measuring when it comes to child mental health, so it is used all throughout the world when it comes to measuring children for mental health issues. And to the right, this is a picture of what the SDQ looks like. And as you can see, the first section is completed by the parent, and then the middle section is completed by usually the child's teacher, and then the last section, if the child can fill it out themselves, they can do so because it's self-completed, or like said before, the parent can fill out those 2 sections, and then the teacher will fill out the middle portion. When it comes to the implications for the SDQ, the SDQ is used quite a bit, and it is because it has a satisfactory rate when it comes to validity. And if the scoring, something good to look for is if the scoring is higher or close to 40, that usually is an indicator of more severity when it comes to the diagnosis of ADHD. And the pro-social behaviors are not included in the scoring process. So that was something that I found very interesting when researching the SDQ. And lastly, it is capturable when it comes to the child learning about themselves and their capabilities. Um, so if the child does not know that they can do something, this assessment will tell the child a lot if they're old enough to understand, because 4 is pretty young. But if they're more of like the teenage um, side of the age part, um, it can really open their eyes when it comes to what they're capable of doing. When it comes to the psychoeducation, looking at gender, a few simple things can be done when it comes to psychoeducation and working with the client. The first thing that came to mind was um, information can be given verbally in therapy sessions. So if any like goals are being talked about, verbally telling the child or the child's parent um, some goal insights that could be thought of when working towards those goals. Um, the therapist can provide some simple homework that is good for um, having the child reach their goals, and any handouts or materials could be given to help reach treatment goals. Um, and also, the parent of the child could do that and simply contact the child's therapist and ask like if it's a good idea or if it could be useful. And lastly, encouraging child and parent together to discover information and share those ideas with their therapist.
For domain 1.10, strengths and problem solving capacity, I used the Ages and Stages questionnaire, or the ASQ for short. The purpose of this assessment is to identify children at risk for social and emotional difficulties between the ages of 6 months to 60 months or 5 years. The questionnaire seeks to measure potential developmental delays in hopes of early intervention. The rationale for why I chose this assessment is because the ASQ can be used to detect ADHD in young children, or at least delays they may experience because of their ADHD. Some of the questions featured on the ASQ relate to the ability of the children to problem solve and is more focused on their strengths. It is highly reliable and valid, and it is already used in many clinical settings. The article by Lamsel et al., used in the bibliography, indicates that the ASQ has a high accuracy for ruling out children for potential neurodevelopmental disorders, or NDD. However, it is not as effective for identifying children with a NDD. Therefore, moving forward, this tool is still useful for identifying developmental delays, but it can also be used to rule out any neurodevelopmental disorders in the population. The implication for clinical assessment, well, this tool is already widely used in clinical study for assessing the strengths and capacities of children, and therefore it should continue to be used for such. In terms of using this to diagnose for NDDs, further research would be necessary to assess the validity of the questionnaires use for that specific purpose. But overall, the ASQ is great for clinical assessment of developmental milestones and can be used to rule out developmental disorders. Psychoeducation and treatment shows us that parents and clinicians should continue to be educated on the usefulness of the ASQ during critical developmental stages of a child's life. Based on current research, the ASQ cannot be used as a satisfactory method, however, to diagnose NDDs. In children with ADHD, the ASQ can still identify areas in their development in which extra support may be necessary in order to overcome challenges. For domain 1.11, income and community resources, I use the Accountable Health Communities Health Related Social Needs Screening Tool, or ACH HRSN for short. The purpose of this assessment is to identify the social needs of patients that have an impact on their overall healthcare outcomes. These needs range from financial strain, food insecurity, lack of reliable transportation, and many others. This assessment aims to target those already in the healthcare system that may be at a higher risk for adverse health outcomes. The rationale for why I chose this assessment is because it can be used to measure the financial difficulties that families impacted by an ADHD diagnosis may face outside of that diagnosis already. For many, access to affordable and equitable healthcare, especially mental health care, can be a major struggle. This tool would be useful for identifying any roadblocks a family may face when treating a child with ADHD. The insight that the article by Hotez et al. In the bibliography determined was that when clients took the survey, it was able to screen over half of the participants as positive for having adverse social determinants of health. However, it was revealed that the initial participation was extremely low. Only about 9% of the population was actually willing to take this survey. Therefore, we see this major disconnect between those in the healthcare system and the needs that are present versus our ability to actually identify those clients that need the support. So the implications for clinical assessment is that while the ACH HRN has demonstrated it is an effective screening method to uncover social needs of clients, a majority of individuals are not willing to take the survey on their own free will. Therefore, it may be important for clinicians to start including this assessment tool as a regular part of their clinical practice, maybe just sitting in the room with the patient and going over the questionnaire and have it filled out. Further, clinicians, once identifying the potential barriers to treatment, should be prepared with referral services for patients based on what their expressed needs were. Looking at psychoeducation and treatment, families need to continue to receive education on how their social status and needs can impact their health, again, outside of this ADHD diagnosis, but then once they have this diagnosis, how that's going to impact each other even further. They also need to receive education on steps they can take to get connected to support that is going to strengthen their capacities. Additionally, clinicians should receive training on how to implement tools such as the ACH HRSN in their practice so that we can uncover more needs of this client population.
In section 12, potential barriers to treatment, the instrument I chose was the FACES IV instrument. This instrument was kind of interesting to learn about. I can say the purpose of the assessment was to evaluate and understand the functioning of family. This assessment usually help assess like family strengths, weaknesses, the areas of intervention, and the FACES questionnaire measures like the communication and the family adaptability. The rationale for this instrument, the FACES IV continues to be the front runner with this work to evaluate the measures to assist family with the challenges. So this means like the FACES IV instrument is like highly recommended and very useful. Insight from the bibliography I use, the FACES IV questionnaire is an effective tool to examine family function in four different scales, so cohesion, satisfaction, communication, and flexibility. Um, while looking into the research, it's shown like family that raises children with ADHD tends to have like very high conflict in the parent-child relationships and between siblings. Parental stress is always like being reported. The implications for clinical assessment. FACES IV has been shown to provide beneficial information into family functioning, which connects to the functioning of the child with ADHD. So, utilizing this instrument can help assist the evaluator understand like the family traits, dynamics, and how they see things or how they choose to go about doing things with the child or how like they run their household and things like that. Treatment. Children with ADHD frequently experience difficulties when experiencing or excuse me when interacting with peers like at school or in the neighborhood, their siblings, sometimes their parents or some family. The level of involvement and interaction that the child has with their family or like with friends or siblings is determines how the child develop like their social bonds. So it really starts at home as well. The magnitude of family adaptation can influence the child's functioning.
To break down our team roles and responsibilities, first and foremost, all group members were responsible for communicating within our own chat, working on our respective parts for the assessment kit, as well as the presentation, and taking turns for creating and attending virtual weekly meetings, which happened just about every single week. And thankfully, we were all able to attend so we could really work on a lot of the project together and check in with each other, which was very helpful. And we all worked on shared documents, which allowed for collaboration within the specific domains. While we did break up the domains, as you can see, Haley was responsible for 1.6, 1.10, 1.11. Siobhan was responsible for 1.3 and 1.12. Jacqueline was responsible for domains 1.4 and 1.7. Mia responsible for 1.1, 1.2, and 1.5, and Sarah responsible for 1.8, 1.9. We did know that even though we kind of split those domains up, we were all welcome to really collaboratively work on the entire project. So it was pretty frequently that we kind of like add in other ideas for other domains and really work together to come up with the best assessment tools and the best research. And we were really all able to um, kind of work together to be able to create a really cohesive final project, but it definitely felt very collaborative, even though we found that breaking up the specific domains was the easiest option to do to be able to like hone in on specific research and take responsibility for just one portion. We all found that we ended up really kind of working with cohesion as a group in the end, and we kind of fell into our roles, especially as we kind of got to know each other a bit and utilize that open communication.
So I think the group process all together went pretty smoothly. What really helped is that we were in constant communication with each other the whole time. Um, we also Several of our group members also reached out to, you know, the professor to kind of get clarification, and that was really helpful. We also did collaborate a little bit with other classmates from other groups just to make sure we were all on the same page. And we all were very just open and communicative with each other. Like if we had questions, we would, ask each other. Um, yeah, and it just felt like the whole time we were all really on the same page.
I just want to let everyone know, like everyone did a great job. I'm grateful for everyone in this group. We worked very well together. We collaborated together. We faced challenges together, and we all helped each other out and get through this assignment. So I'm just grateful of you guys, and I enjoy working with this group.
To provide an overall summary of the group collaborative process, I really wanted to highlight some of the things that I thought that we did well as a group, specifically relating to the overall communication that we were able to demonstrate within each other. We really made sure to focus on frequent communication, which involved having weekly meetings, which gave us time to brainstorm, collaborate, voice any concerns, ask questions to each other. Specifically, the dates we met were 9/28, 10/5, 10/12, 10/19, 10/26, as well as 10/29. During the first meetings, team members were able to engage with each other and get to know each other a bit, as well as share any ideas that we had about the best way to format the project, how to complete the assignment, and also how to break down the steps required of us to really make it more understandable for all of us to be able to keep on track and hold each other accountable. We also found that working in phases was really helpful. So it kind of broke down the way that those phases kind of played out, and which kind of meeting, how we handled what was required of us to be able to ensure that we were finishing in a timely manner. So the first brainstorming meeting was really us just reviewing the assignment, asking each other clarifying questions, and we also planned a rough draft, which was very helpful when it came to making a measurable timeline to ensure that we were going to finish on time and that we were going to stay on track and keep each other accountable. And we also made a shared document where all team members were encouraged to really brainstorm any questions about assessments for each domain and really get a head start with what we would find more interesting. In the next meeting on 10/5, we reviewed this assignment and we really thought about what domains were going to be best suited to our interest. And this is when we actually broke up the domains in regard to what was most interesting and most applicable to what our experience was in and what we wanted more experience in, which I felt was one of our strongest suits as a group. We really tried to hear each other out and make sure that everything was fair. And during this kind of early planning phase, we also really laid out what each team member's responsibility was in regard to what we felt we were able to live up to. And we made sure that we were pretty forthcoming in what we expected of each other and how we were going to carry out the entire process. Throughout the next few meetings, we really just were updating each other, asking clarifying questions, collaborating, making sure that we were all sort of on the same page with our progress, and making sure that if anyone needed some extra help, extra clarification, that we were all there to support each other. In the last few meetings, we were really just going over the different parts, making sure that we all felt comfortable with what our progress was looking like, and then, of course, planning out our PowerPoint and filming for that last one. I thought that our team did specifically a few things really well. I think that we were able to carry out each portion of our presentation in a way that we felt suitable for our own working style, but we also made sure that we had cohesion to get us on track with the overall completion of the project. So I felt that we were able to really utilize our own autonomy in making a bigger kind of group effort. We all put in very equal amounts of work, I feel, and I think one of another strong choices that we were able to make was having a group chat where we communicated almost daily for several weeks to really not only build up our group cohesion, but it's also really strengthened dynamics between us regarding roles and expectations. And we were really able to utilize communication to have an open format to, really voice any concerns that we had and be transparent. And I feel like that was really helpful with our overall understanding of the project to be able to make sure that we're getting something out of it, and also completing on time and making sure that we all feel like we are being seen and heard. So overall, I think that our group dynamics were very strong, and I think that the biggest reason behind that was the fact that we were all very understanding and willing to communicate and collaborate with one another.